arterial supply, venous drainage, lymphatic drainage, all that. Any questions about all of that? Is it pretty clear? Okay. So then let's finish up the pectoral region with the pectoral muscles. This should be a nice, easy review for you guys since we've been covering this in lab. So we have this muscle here, the pectoralis major, inserts on the, or originates on the clavicle, the lateral margins of the sternum and some of the coastal cartilages, and inserts on the excuse me, upper humerus. And what's the action of the pectoralis major?
Adduction.
Flexion, rotation.
Medial rotation.
Yep. Medial rotation of the humerus, flexion of the upper arm, adduction. Correct. Okay, we also have the pectoralis minor here, and its insertion and origins are where? In general, you don't have to be real super specific.
Rib 1 to inferior surface of clavicle. Oh, sorry. Pectoralis minor.
Minor, yeah, pectoralis minor. So the
Ribs 3 and 5.
yeah, and coracoid process of the clavicle, and its action is to
Depress shoulder.
depress the tip of the shoulder. Correct. And I add another muscle to the mix, the subclavius. Please don't die on me, psycho thing. It goes from rib 1 here to the clavicle, and excuse me, helps to stabilize the sternoclavicular joint here by pulling the clavicle in. Oh, you cannot see that pull. Pulling the clavicle in towards the sternum. Excuse me. So just add subclavius to the list of muscles that you already know and should know well. I also want to point out the clavipectoral fascia. It's a bundle of fascia that surrounds the pectoralis major and the subclavius, and is part of a region here called the axilla. And don't do that. Come on. The axilla is one of the major passageways from the thorax into the upper arm. Some major arteries, veins, lymphatic vessels, and nerves all pass through that area. Okay. Any questions? Pretty simple. Okay. All right, so then we'll talk a little bit more in detail about the thorax, the wall of the thorax. So like we know, it's composed of this kind of barrel-like structure where the vertebra, the ribs, and the sternum make a complete, come on, here we go, a complete ring around the thorax, effective ring. So we'll pull apart each of these sections. We've already talked about the thoracic vertebrae. In your notes, I just have a reminder of the specific characteristics of those vertebrae. So the heart-shaped vertebral body, circular vertebral canal, blah, blah, blah. One thing that I didn't mention before that I did add to those notes is that the transverse processes are rather club-shaped. And that's one way we can differentiate between those and the longer, thinner process, transverse processes of the lumbar vertebrae. All right. So then let's talk about the ribs in a little more detail. So we should all be familiar after studying them the last couple of weeks in lab. We have several different portions of it. So the head is what articulates with the vertebral bodies. We have the superior and inferior articulating facets. And then this here, this ridge in between is called the crest. And that will be important when we talk about actually how that joint is put together. We have the tubercle, where we have muscle attachment, muscle and ligament attachment, and also a facet for the transverse process. An angle where the rib starts to curve and twist around the barrel of the thorax. groove here where, the intercostal vessels and, nerves run. And then finally, we have a continuous articulation, so symphysis style articulation with the rib bone and the costal cartilage here. Excuse me. Whoops, too far. Okay, so then I just want to point out on this figure, this is looking at the rib from the opposite angle. We have the articular and non-articular parts of the tubercle. The articular part is the facet for the transverse process. The non-articular part is ligament and muscle attachment. And it would be a good idea, just as a hint, to know maybe a couple muscles that attach to that point. That might be on a test someday. So then we have these typical ribs, so the ribs 3 through 9 have this general structure, with all of the, major components we've talked about. I want to quickly jump back to here and just point out we have the false ribs here that don't directly connect to the sternum. They connect to the costal cartilage of ribs above them, and then the floating ribs that do not have an anterior attachment point. They're just rounded. And they have slightly different articulations with the vertebrae as well. So what's the importance of ribs? Well, protect us, the thorax obviously from damage. So when there is some sort of crushing or some sort of blow to the thorax.
Can you go back to the previous one?
Which previous one are you talking about? When I
The
jumped
slide
around?
right before this one. Okay, so this one, it's a posterior review. And in the notes it says that the inferior articular facet faces anteriorly, but if this is a posterior review, the inferior facet, isn't it facing posteriorly right now?
Where are you looking at in the notes?
Under your skeletal framework.
Oh, that's the thoracic vertebrae, so this, superior articulating facets.
Was for the
For
vertebrae,
the
not the
vertebrae.
rib part.
Mhm.
Okay,
Yeah,
thank you.
no problem. So, any type of blow or force that's going to compress the thoracic structure has the potential of fracturing the ribs. Typically it's the middle ribs that are fractured because they have the continuous attachment from the sternum to vertebrae, and they're not protected like the first rib is, so the first rib is protected. Very often it's just, the fracture is just anterior to the costal angle, so if that's kind of back here on the back here, I can tell you that's where mine got broken when I did my thing. And there can be obviously variations in severity. With a very severe displaced fracture of the rib, you can have problems with internal organ rupture, or a diaphragm tear, causing a lot of internal damage. A lot of rib fractures, thankfully, are stable. And they just hurt like the dickens for 6 weeks, especially when you breathe and stuff. Cough, sneeze, talk, everything. Multiple fractures in the same area can cause what we call flail chest, which is basically that part of the rib cage is so sufficiently separated from the rest of the rib cage that it's now acting more as on the cues of the pressure inside the thoracic cavity rather than the muscle actions of the rest of the rib cage. So actually, when you inhale, that part will depress as the pressure in the thoracic cavity is decreased. So you'll see it actually working in opposite motion of the rest of the thoracic wall. Sorry?
Perivascular movement.
Yeah. So so it moves opposite. So opposite movement. dislocation or separation of the rib. So dislocation defined is displacement between the costal cartilage and the sternum, whereas separation is defined as displacement between the rib and the costal cartilage. Just know those differences. Okay. Also, when thoracotomy is done, this can be, to gain access to the lung or some other thoracic structure. Part of what they do is remove part of the ribs. You can see here it's been excised in the incision site here. But what they do is they very carefully peel the rib out of the periosteum and maintain the periosteum as intact as possible. And what happens is with that intact periosteum, we end up having the rib grow back over a period of minimum time frame I saw was about 2 months, and then beyond that, depending on the amount of rib that needs to be regrown and the health of the individual, etc. So, just greater than 2 months. But it's pretty awesome to be able to excise a part of a rib and have it grow back. I think pretty cool. All right, questions about ribs? Pretty easy. We've been studying it all. Should be a lot of review. All right, so then so I'll move on to the sternum. Just review some of the
See what happens.
the
Hey,
different
dude,
parts
can I
of
get
the
out your
sternum.
rib?
So we've got the manubrium here
I
up top,
promise. I
and
think
then we have the
It'll grow
jugular
back.
notch, which is that palpable
think.
area right at the top medial portion of the manubrium, which can give us a skeletal landmark for looking at other portions of the thoracic skeleton. So one of them would be identifying attachment site for the first rib. The sternal angle is also a very useful. Come on, don't do that to me today. Very useful for finding the articulation of rib 2, because it's right at that joint where we have the articulation of rib 2 with the sternum. Also on the manubrium is we have the articular site for the clavicle on either side of the jugular notch. Then obviously xiphoid process at the bottom, and all of the articular facets for the rest of the ribs along there. So just know them, be able to identify them, all of that good stuff. Just one note, embryologically, the transverse ridges are due to excuse me, the fusion of the sternum as the child develops. So embryologically, the sternum is a lot of segmental structures, and then later on in development they fuse into the sternum, and that the transverse ridges are then leftovers of that fusion process. Okay, so then sternal fractures, but you probably are going to get that only after a very, very severe injury, or if you have some bone fragility. So you're a lot more likely to get your ribs fractured than not. You can have them in elderly people, especially at the sternal angle, as that joint is not as strong anymore. And then you have comminuted fractures, which basically means you've got the sternum breaking in several different locations, and that is due to severe trauma and very often correlated with heart injury because of the severity of the trauma required to cause a sternal fracture. So you'd expect to also see a myocardial contusions, so just bruising and battering of that heart muscle, cardiac rupture, or tamponade. Okay. We also, the sternum is important because during open heart surgery, often we'll do a medial sternotomy, so splitting the sternum down the median plane, and often for like coronary bypass. final line we'll just mention is, the xiphoid process, so it's typically a joint, an actual joint with the body of the sternum can become ossified. Excuse me. And ossification, produces a hard lump, which patients will sometimes mistake for, a tumor, so get all worried about that, but nothing to worry about. Okay, so this is just some clinical application of sternum. Alright, so then let's talk about the joints between all of these, skeletal components of the thoracic wall. So we have the joint with the vertebral body. Excuse me, oh my goodness, this is not fun. Called the costovertebral joint. And it's a novial joint, so you can see in this increased magnification section here, you can see the joint cavities, little synovial membranes here. You also can see that they're separated, so the articulating facets, superior and inferior articulating facets, and their joints with the vertebra are separated by the intra-articular ligament, which helps stabilize that joint. And that is continuous with the intervertebral disc. The joint capsule of this joint surrounds the entire joint, so there's not a separate joint capsule for the superior and inferior articulating facets. Then we have the costotransverse joints. Here we go. This is where we know. And that's obviously between the rib and the transverse process. It's also a synovial joint and stabilized by the superior costotransverse ligament, the costotransverse ligament, and the lateral costotransverse ligament. So they all work together to stabilize that joint. Excuse me. I'll just point out a few exceptions. So on rib, or the vertebra T1, the articulation with rib 1, there's a single articulating facet rather than the two articulating facets we have with the rest of the ribs. The same is true for vertebra T10 and rib 10. So here we see the single facet. And then for rib 11, we not only have just a single articulating facet, but we have no facet on the transverse process. Excuse me. And all of these, again, are synovial joints. So here's the joints of the sternum. So we have two different types of joints. We have the symphysis type joint with the manubrial sternal joint and the xiphoesternal joint. And symphysis joint is what? What kind of joint is that? Can't hear you. It's a solid joint composed of
Fibrocartilage.
fibrocartilage. Very good. And then the rest of the joints between the costal cartilage and the sternum are synovial, often with those at the junction between the sternal body and the manubrium being two-faceted. And then we also have the synovial joints between the chondral cartilage of adjacent ribs on the lower ribs, and those are the interchondral joints. So these are the is it sternocostal or costal? Sternocostal. So be able to identify them, know the right name, know whether they're synovial or symphysis. All right, so then let's kind of look at the intercostal space for a few moments. So we have that the intercostal space is named for the rib below it, so that if this is rib, oh, let's make it rib 4, and this is the intercostal space 4 up here. So we have obviously the ribs, and then we have the intercostal muscles that we'll talk about more in a little bit. And then we also have the endothoracic fascia, which is a connective layer between the intercostal muscles and ribs and the pleura, yes.
So the space in between the ribs is the number above the rib?
So it's named for the rib below it. So if this is costal, this is rib number 4 here, then this is the intercostal space 4.
Okay. Where would be the first? Do we not have a first?
We wouldn't have the first because it's
Okay.
above rib 1, and that would just be your thoracic aperture.
Okay.
Yeah, good question. Okay. Endothoracic fascia just helps the ribs and the pleura glide past each other smoothly, and it can contain a variable amount of fat. So in an obese patient, you may see quite a lot of fat deposition.
Could you please repeat that?
Okay, so the endothoracic fascia can contain variable amounts of fat. So in an obese patient, you may see quite a bit of fat stored there. All right, so then let's talk about the muscles of the thorax in more detail. Some of them we're quite familiar with after studying them the last couple of weeks. I'm going to add another one to it, the subcostal muscles. So these are a deep muscle on the interior surface of the thoracic wall. Excuse me. So they attach to the interior surface of the rib near the costal angle. So that causes the placement to vary slightly as far as the distance from the vertebral column, and then they go down to either the second or the third rib below it and adhere to the superior internal surface. And based on their placement, what would the function be? What would you think? When they contract, they're going to
Bring them closer.
compress the ribs. Excuse me. All right, so that is the subcostal muscles. This one we're all familiar with, the transversus thoracis, attaches to the sternal body and the xiphoid process, and it goes out to the costal cartilages and the ribs adjacent and above it. We also can have additional portion of the muscle going up to this rib. It's not shown on this diagram, but that's very often seen. So up to rib 2. And the action of this rib is to, pardon?
Depression across the
Yeah. Depress costal cartilage. All right, and then finally we get to our intercostal muscles. So we've all been studying those. The external costal muscle obviously is the outermost layer. Then we have the internal intercostal muscle, so it's the inner layer, and then the innermost layer, which is the deep to the intercostal muscles. Just one thing I want to point out with them, excuse me, intercostal muscles, its orientation is inferior. I'm not even going to try to say it. This is not going to happen today. So it goes from the posterior to anterior. It slopes inferiorly, and so when it contracts, what is it going to do? What do you think?
Back's
Is it more likely to pull the ribs up to it or pull the ribs down? So look at the angle. when it contracts, the rib below it is actually gonna be more likely to elevate slightly, so this is actually elevation of the ribs. Excuse me. So, and this is often, active in inspiration. Okay, so that is external. Internal and innermost work together, and their orientation is the opposite. You see it's moving back, from anterior to posterior as it goes, from the rib above to the rib below. And so then it's going to depress the ribs. And it is most active in exhalation. Excuse me. Okay, so that's the musculature of the thoracic wall. So there's been a lot of review. We've been going over it in lab. So it's just another repetition so we can get it stuck in the head forever and ever. Alright, so then let's talk about arterial supply. So we've also talked about this in lab and in previous lectures. I'm just going to add a couple layers on top of what we've learned already. So we have the posterior thoracic aorta, which supplies a lot of our posterior intercostal arteries. But at the top here, we have something a little different. So we have the two uppermost intercostal arteries actually are branch off of the subclavian artery. So the way it goes is subclavian artery branches to the costocervical trunk, which then branches into the supreme intercostal artery, which then branches into the two topmost intercostal arteries. So just know that sequence of events there. You can see it coming off of the subclavian here, then branching here, and they don't show that final branch, but just know that sequence of vessels. So
that branch is the top intercostal arteries?
The top two intercostal arteries. And that would be the posterior. Okay. Excuse me. I really am not sick, it's just allergies, so you won't get deathly ill from all of this hacking. I promise. Okay, so there's that one. And then for our anterior intercostal arteries, they are a branch off of which main artery?
Subclavian.
So we have the anterior intercostal arteries coming from the, I can't hear you guys.
Internal thoracic.
Internal thoracic, thank you. And that's a branch again off of the subclavian artery. So know that pathway as well. All right, the internal thoracic artery, as it reaches the lower margins of the rib cage, actually splits into the superior epigastric artery, which continues on down past the diaphragm and innervates the anterior abdominal wall. And then the musculophrenic artery, which travels along the costal margin, passes through the diaphragm, and supplies the lower intercostal spaces. So there's just a few more arteries to add on top of the ones we've already discussed. And for me, understanding the pathway the blood takes is important. So know where each artery is coming from, where it's going to, what it branches off of, what it branches into. Those are all important things to understanding how this portion of the circulatory system operates. Excuse me. All right, so then we'll switch to the veins. And again, we've studied some of them already. So we have, this one here, internal thoracic vein, and you remember where it empties into?
Brachiocephalic.
To the brachiocephalic veins, yep, so here we go, brachiocephalic veins. There we go. And the anterior intercostal veins branch off of, or feed into the internal thoracic artery. We also have the right superior intercostal vein here, which excuse me, empties directly into the azygos vein. And these are the top, again, the top couple of intercostal veins come up into this right superior intercostal vein. But on the left side, it's different. The left side, the left superior intercostal vein actually, excuse me, empties into the left brachiocephalic vein. So there's some differences between left and right sides there to make note of. All right. Questions about that? Pretty simple, straightforward, just about it. Come on, let's go for it. There we go. And we'll talk about some more of the perforating vessels in a moment. So we'll come back to those. We just want to make sure we're familiar with the lymph node locations and drainage, the lymphatic system. So parasternal nodes next to the sternum, obviously. Diaphragmatic nodes associate with the upper surface of the diaphragm, and actually also interconnect with the parasternal nodes, the lateral aortic nodes, and excuse me, several others that I'm not going to mention. I think I have them listed in the notes, but so that these are very much interconnected with all the rest of the nodes in the area. We have intercostal nodes in between the ribs, very, very similar projection as the intercostal veins and arteries. And those I'll empty into typically the bronchomediastinal trunk. Oh my goodness, still not having a good time with those. Or the thoracic ducts, mainly the drainage there. Okay. So again, just know locations of those nodes, know their names, be able to identify where they are and where they're going to drain into. So then let's look at the perforating vessels and also the innervation of the thoracic wall. So you can see here the posterior branches of posterior intercostal artery and vein branch off into these lateral branches here, and then they actually go out of the thoracic wall and innervate this, supply the skin and overlying structures on the lateral portions of the thoracic wall. We also have those anterior perforating branches of intercostal vessels there, giving again cutaneous and excuse me, cutaneous and arterial supply to the breast as well. So then we also have the spinal nerve. So the posterior ramus of the spinal nerve is the main one that innervates the thoracic wall. You should know that. It also branches here laterally. It sends collaterals out along the exterior surface of the thoracic wall. And then here, kind of towards the end of the intercostal nerve, it also protrudes out of the thoracic excuse me, wall, and branches into a lateral and medial branch. So this is the medial and lateral branch of the nerves. to, again, provide cutaneous innervation. Excuse me. Also want to mention, do I have it? Let's see. Yeah, not as visible in this image, but still possible to see it. These intercostal veins, arteries, and nerves all are in the costal groove, as we've learned, between the innermost and inner layers of the intercostal muscles. And typically, and this is kind of an acronym that works for a lot of the main nerves in the body. Typically, we have them in the order of nerve, then artery, then vein. And if there's a lymph vessel involved, it's often above the vein. So we can use the acronym NAVAL to help us remember that often nerves are more lateral or further away from the bone, the structural support, followed by the arteries, veins, and then lymph vessels. That just helps, this helps me remember which way they're going. So it's lateral, medial, or distal, proximal kind of thing. All right. Any questions about that? Okay. All right, so then let's look at a cross section. So this gives us just a little bit of a cross section of intercostal spaces. So we don't see any ribs there. Typically, the ribs would be showing up as little sections, because as the ribs descend down the thoracic wall, they would show up something along those lines. And we can see here the lateral cutaneous branches of the intercostal nerves. You can see the layers of the intercostal muscles, so the innermost, the internal, and the external intercostal muscle. You see how they're oriented and how the cutaneous branches of the vessels and nerves are coming through the internal and intercostal muscle layers. You see orientation of the internal thoracic artery there. And then also the anterior cutaneous branches, and also called the perforating branches. So those are, excuse me, synonymous, that's the word I was looking for. And you can see here how it's the anterior ramus here coming out to innervate the thoracic wall, while the posterior ramus, as we learned in the back section, innervates the back muscles. Okay. Questions about that? So be able to identify structures on a cross section as well as a image like what we have been seeing. All right, so then the clinical application. So when a patient has either air in the pleural cavity, so pneumothorax, or fluid in the pleural cavity, we'll often use a chest tube or some sort of syringe to pull out the fluids or the air in the area. And just a note, is typically inserted just above the superior margin of the rib. So it keeps well away from this area where we have the intercostal vessels and nerves. So always coming in over the top of the rib. And often with the chest tube, it's actually inserted here and then snaked up through here to maintain a slightly more complex path from internal to external environment. So it's going to be a chest tube. Okay, any questions? So I kind of blazed through that because I want to talk as least amount as possible today, so I still have a lab to run this afternoon. So if there's no questions, you guys get out of class a little early.